Automatic decisions are also referred to as recognition-primed, pattern recognition, or intuitive decisions, and they depend on prior knowledge. We recognize a situation, refer to our prior knowledge of it, and use that knowledge to decide what to do. With familiarity, such decisions normally become both automatic and unconscious. When we drive to work, we may be completely preoccupied with matters unrelated to navigation, yet at each road junction we still drive with due care and attention, and decide to go the correct way. Automatic decisions are our default way of managing everyday activities, such as getting up, dressing, having breakfast, and driving to work. The processes are normally simple and use existing situation awareness rather than relying on the situation awareness related steps of assessment, option checking, and review that are part of analytic decision making. It would be too laborious to assess and option check every tiny choice in life. Early laboratory experiments were designed to investigate things like ethical, career, or purchasing decisions for market research. These experiments were not about decision-making models, but when subjects are asked to make decisions about unfamiliar situations, they make them analytically. This model of analytic decision-making was derived from this body of results, and when researchers started to study real-life decisions made by experienced personnel, they found the model did not fit. This led to the terms classical decision theory for the experimental analytic type and naturalistic decision theory for the real-life automatic type. Most real-life decision-making is helpful and accurate and based upon unconscious automatic pattern recognition. A stream of automatic decisions is essential to keep a complex organization like a hospital working at all, but it can also let you down.
The young doctor's first day in accident and emergency was a bit of a shock. A male patient in the resuscitation bay with 4 recent admissions for severe asthma had arrived and was unable to speak. A quick chest examination revealed very little wheezing, which comforted the doctor somewhat. He then tried, with some difficulty, to get the rest of the patient's history and the examination done, just as he'd been taught at medical school. The patient's consciousness level suddenly deteriorated and his heart monitor showed a slow rate with bizarre ECG complexes. Cardiac arrest was imminent, so the doctor summoned help. After a few minutes of hectic activity, the patient was safely anaesthetised and ventilated, receiving treatment for severe asthma and a precipitating chest infection.
The doctor's problem here was the use of faulty automatic decision-making and a failure to redress this using analytic thinking. He matched a simplistic pattern. Asthma makes people wheeze. More wheeze equals worse asthma. Less wheeze equals less severe asthma, and the patient's relatively quiet chest made him match it to the mild attack pattern, which he managed accordingly. He could not pattern match correctly because he had no prior experience of this type of case, but he was told of it during his training. If he had changed to analytic mode and assessed the situation with other guides to attack severity, such as measurement of peak airflow or blood gases, he would have got it right. If someone lacks experience, analytic decision-making can compensate, but it must be engaged. Experienced doctors, in consultation with patients, rapidly narrow a diagnosis down to 2 or 3 likely possibilities. They interrupt patients early in a consultation, on average after only 18 seconds, to ask specific questions that help them distinguish between these possibilities. This rapid and effective system depends on much automatic decision-making and little analytic. It contrasts with the way these same senior doctors teach diagnostic skills, and a far longer list of diagnostic options would be on the classroom blackboard. This contrast is because teaching can only inform an analytic approach. Automatic requires experience. Experienced decision makers may take only seconds to recognize a pattern and take action, while a novice is still trying to understand the problem analytically. This can be illustrated in the field of anesthesiology, where there can be a drop in blood pressure during induction of anesthesia. Detecting and managing this situation becomes so routine that an experienced anaesthetist will see the pattern and proactively treat with corrective drugs, while a novice will still analyse and wonder whether to call for help or delay the start of surgery.
An experienced cardiologist who happened to be in accident and emergency came to the assistance of a young doctor. The young doctor's heart patient had suddenly become very sick, and within just a few seconds, the cardiologist's stethoscope revealed the distinctive heart murmur sound of a ruptured heart valve. Immediate open heart surgery saved the patient, following this rapid and accurate decision. In this situation, the cardiologist was unaware of any thought processes in making their decision.
The danger, of course, of pattern matching is picking the wrong one. Once in a while, a drop in blood pressure will be the first sign of a serious situation that cannot be easily corrected, for example, a drug allergy. If the pattern is not corrected to the right one and no change to analytic decision-making is made, a wrong decision is likely. Increasing experience makes us better at recognizing more patterns, and so increases our use of this method. But at the same time, it reduces our opportunities for analytic decision-making. Rule-based decisions become automatic when we're practiced at them, such as stopping at a red traffic light. Experienced drivers do it automatically with a high but not perfect degree of consistency. Automatic decision-making is also resistant to change and may be made inappropriate by contextual changes. When driving in another country, for example, where original learning interferes with new learning. Here, in general, the more experienced you are with one system, the more interference there will be with new learning. Also, not all rule-based automatic decisions are good, such as deciding to have another cigarette. They can be particularly difficult when policy changes are planned. Recent concerns about hospital-acquired infections in the UK have prompted policy changes on dress and hand washing by staff on wards. This sounds easy, but what was needed was changing an automatic decision on actions when entering different wards. Just telling staff was not enough. They were acting automatically, and it was difficult for them to override their decisions analytically. After considerable exposure, discussion and effort, the new policy became an automatic rule-based behaviour, and healthcare managers could use the term embedded with unwitting truthfulness.